Hello, welcome to the part 2 of our CNS infections lectures. I am again Dr. Carlo Magno Alejandrino to present viral meningitis and encephalitis. Viral infections of the central nervous system are among the most common causes of meningitis and encephalitis worldwide. Enteroviruses, herpesviruses, and arboviruses are the most frequent culprits, though epidemiological trends may vary by region and season. The herpes simplex virus is the leading cause of your sporadic encephalitis that includes both HSV1 and HSV2. Your varicella zoster can cause meningoencephalitis, and cytomegalovirus are usually seen in immunocompromised patients. Enteroviruses such as Coxsackie virus and echovirus account for 85 to 90% of viral meningitis cases, and they are most prevalent in summer or early fall. Your arboviruses, such as your West Nile virus, St. Louis encephalitis, Chap encephalitis virus, Eastern equine encephalitis virus, are seasonal outbreaks spread via mosquitoes and ticks. Your rabies virus is transmitted through animal bites and nearly 100 fatal once the symptoms show up. Mumps virus are vaccine preventable cases of viral meningitis, and they are most common in unvaccinated populations. Viral CNS infections occur via two primary routes of entry: hematogenous spread and neuronal spread, with hematogenous spread being the most common. For hematogenous spread, virus enters bloodstream, crosses the blood-brain barrier, and invades the meninges or brain parenchyma, typically for enteroviruses, arboviruses, and mumps virus. For neuronal spread, the virus travels along the peripheral nerves to the CNS. This is seen in HSV, VZV, and your rabies virus. Rabies virus follows retrograde axonal transport from the bite site to the brain. Once inside the CNS, your viruses can cause direct neuronal damage and inflammation and immune-mediated injury. They manifest with fever, headache, photophobia, and neck stiffness. Lymphocytic findings will show lymphocytic predominance, normal and mildly elevated protein, and normal glucose. It is usually self-limiting and resolves in 7 to 10 days. Viral has more severe neurologic symptoms than viral meningitis. It presents with altered mental status, confusion, seizures, and focal deficits. The most common cause will be your herpes simplex virus 1 encephalitis, which cause temporal lobe necrosis, arboviral encephalitis, and your rabies virus. It has higher mortality and long-term sequelae. Your rabies encephalitis will have a clinical manifestation of fever, malaise, paresthesia at bite site during the prodromal phase, and your neurologic phase is divided into two: your furious rabies, which will have hyperactivity, hydrophobia, and aerophobia, and your paralytic rabies, which will present as flaccid paralysis and coma. Again, for rabies encephalitis, once symptoms appear, rabies is nearly 100% fatal. The CSF picture for your viral meningitis includes WBC count of 50 to 500 cells per microliter with lymphocytic predominance, normal glucose, which differentiates it from bacterial and fungal meningitis, with mildly elevated proteins. PCR testing is beneficial for HSV1, HSV2, and enteroviruses, including rabies virus also. Serology may be beneficial for arboviruses, and imaging will show temporal lobe involvement in HSV encephalitis and basal ganglia thalamus hyperintensities in West Nile encephalitis. For treatment, your HSV and varicella zoster encephalitis will respond to IV acyclovir for 14 to 21 days. Your CMV encephalitis, which is common in immunocompromised patients, will benefit from ganciclovir plus foscarnet, and your rabies virus will benefit from rabies vaccine series, rabies immunoglobulin HRIG, and no effective treatment after symptom onset. Supportive care includes seizure control, ICP management, and ventilatory support in severe cases. So prevention is key, no? Vaccination, rabies vaccine for high-risk individuals, mumps, measles, and rubella vaccines also advised, Japanese encephalitis, yellow fever vaccines for travelers. You also need mosquito and tick control. Insect repellents may be used, elimination of standing water to prevent mosquito infection. Prognosis and long-term outcomes. For viral meningitis, usually it has a good prognosis, full recovery in most cases. HSV encephalitis will have high mortality if left untreated, up to 70%. But early acyclovir reduces mortality to approximately 20%. Arboviral encephalitis is variable, with West Nile with 10% mortality, Eastern equine encephalitis with 30 to 50% mortality. Rabies encephalitis, again, emphasized, nearly 100% fatal once symptoms appear. Okay, so let's talk about the herpes simplex encephalitis. Herpes virus are large double-stranded DNA virus with an icosahedral capsid and envelope containing glycoproteins. HSV1 and HSV2 belong to the human herpes virus, or HHV. All HHVs except Kaposi sarcomas virus can cause encephalitis. HSV1 in 90% of the cases and HSV2 10% of the cases are the most common causes. So the primary infection is on your epithelial cells or of the mucosa or the skin. It spreads neurally via the peripheral neuron axon terminals, and it is transported retrogradely to neuron cell bodies, which establishes your latency. Latency mechanisms include your suppression of the viral lytic genes via histone deposition, activation of intrinsic and innate immune responses, and immunocompetent hosts prevent systemic spread. HSV1 is the leading cause of sporadic encephalitis worldwide, with no seasonal variation. HSV2 is more associated with neonatal encephalitis and recurrent aseptic meningitis. HSV1 is seropositive in 60 to 90% in older adults globally and 50% in the US, ages 14 to 49. HSV2 is seropositive. Seropositivity of HSV2 is higher in women due to increased sexual transmission and 16% seropositivity in the US. Annually, there are 2 to 4 cases per million globally. Without treatment, you have 70% mortality. Again, with early acyclovir, you can lower that to 20 to 30% mortality. There are 20 to 50% encephalitis cases which are viral, and HSV accounts for 50% to 75% of the viral encephalitis cases. Herpes simplex encephalitis is the most common infectious encephalitis in the UK and most frequent cause in hospitalized encephalitis patients in Australia. Similar incidence in Sweden and the US. It is most common and severe in children and older adults, and one-third of cases occur in children and adolescents. 50% of cases in patients more than 50 years old, and both sexes are affected equally. Transmission and primary infection. HSV1 and HSV2 require close contact for transmission. HSV1 is usually transmitted via saliva, leading to oral or pharyngeal infection, while your HSV2 is typically sexually transmitted, leading to genital infection. During primary infection, the virus replicates in mucosal or epithelial cells, causing inflammation and herpetic lesions. After initial infection, the virus travels via sensory neurons, establishing your latency. HSV1 resides in the trigeminal ganglion, and HSV2 remains latent in the sacral ganglia. Reactivation can occur due to stress, immunosuppression, or other triggers, allowing the virus to travel back to the periphery or invade the CNS. So the mechanisms for CNS invasion, your HSV1 reaches the brain through three possible routes. One, retrograde transport via the trigeminal or olfactory nerves after an oropharyngeal infection. Two, it can be due to reactivation of HSV1 within the brain, where it had been previously established. And three, hematogenous spread, although this is the rarest. HSV1 encephalitis predominantly affects the temporal lobes and limbic system, leading to hemorrhagic necrosis, meningeal congestion, and perivascular inflammation. In neonates and immunocompromised individuals, the infection can spread more diffusely to involve the brainstem, cerebellum, and your cerebral cortex. So, cross pathology of your herpes simplex encephalitis, there are hemorrhagic and lytic lesions commonly found in the medial temporal lobes and inferior frontal lobes. Brain biopsy hallmark includes your hemorrhagic encephalitis in orbitofrontal or limbic regions. So, in the early stage, there are cytoplasmic shrinkage of infected neurons, capillary dilation and hemorrhage, and there are Cowdery type A inclusions, or which are eosinophilic intranuclear inclusions. Viral antigens in the temporal lobes, hippocampus, insula, and olfactory cortex may also be identified. During the subacute stage, there is neutrophilic infiltration of the infected areas. After 10 to 15 days, during the chronic stage, your macrophages and lymphocytes replace the neutrophils, and there is progressive necrosis, inflammation, and gliosis. After 3 weeks, frank necrosis with extensive gliosis and inflammation will be present, and viral antigen detection decreases except in immunocompromised patients. So this is an image of Cowdery type A inclusion body. And on the right, it is a coronal section of a brain with acute HSV encephalitis with hemorrhagic lesion in the right medial temporal lobe. So your herpes simplex encephalitis may typically present with an acute or subacute onset, often preceded by a prodromal phase of fever, malaise, headache, and nausea. The hallmark symptoms include altered mentation lasting more than 24 hours and brain inflammation signs such as fever, headache, seizures, and focal neurologic deficits. Common physical findings, you have 80% will present with fever, 72% will present with altered mental status, and meningeal signs may be present but are uncommon. And acute neurologic deficits include focal cranial nerve palsies, hemiparesis, aphasia, ataxia, visual field defects, and papilledema. Children may present with fever, lethargy, altered behavior, sleepiness, focal seizures, or neurological abnormalities. Neonates 1 to 3 weeks old may be irritable, lethargic, with poor feeding, tremors, or seizures, and herpetic skin lesions are also common. They may have altered liver function test or thrombocytopenia when part of multi-organ involvement. HSV2 may rarely cause associated myelitis. For immunocompromised patients, they can present atypically or subtly, with fewer prodromal symptoms and focal deficits complicating your diagnosis. T-cell targeting medications such as natalizumab, TNF alpha inhibitors may increase susceptibility to HSV encephalitis. Lumbar puncture is still the gold standard with CSF findings of elevated opening pressure, elevated protein, normal glucose. Pleocytosis, lymphocyte predominance is approximately 95% sensitive, but may be absent early in children or immunocompromised patients. There may also be elevated RBCs due to temporal lobe hemorrhage. HSV PCR is highly sensitive and specific, 96 to 99% respectively, and positive in the first week of treatment and negative after 10 to 14 days. False negatives may occur in early infection, and blood contaminated CSF will have hemoglobin interference or after more than 48 hours of acyclovir. If initial PCR is negative but suspicion is high, you can repeat your PCR in 3 to 7 days, and HSV IgM antibodies in CSF is useful for delayed diagnosis. Blood tests include your CBC, coagulation studies, and metabolic panel. It may show mild leukocytosis with lymphocytosis. And HSV PCR in the blood can be helpful in neonates or immunocompromised patients when lumbar puncture is deferred. So neuroimaging, CT scan is the first line test to rule out mass effect, hemorrhage, or increased ICP. Of course, before lumbar puncture again. Often normal in early infection, changes take 3 to 4 days to appear, and it may show hypodensities, hemorrhage, edema, and contrast enhancement may take a week. So this is a patient with HSV encephalitis. Uh, Picture A is an early stage HLCT image which shows almost no abnormality. And picture B is late stage pre-contrast, showing hypodense lesion with a hyperdense hemorrhagic component. And your sulcal meningeal enhancement was seen during the contrast imaging. MRI is most sensitive, with more than 90%. Classic pattern, you have your temporal lobe involvement, unilateral or bilateral, with progression to limbic system, inferior frontal lobes, and insular cortex. T1 shows hypodense in T1, and T2 flare shows up as hyperintense lesions. So thalamic involvement is detected on flare, but basal ganglia typically is spared. Children and immunocompromised patients may have atypical patterns involving your brainstem, cerebellum, and your midbrain. So this is the flare image showing extensive abnormal high signal in the classic distribution of your HSV, the medial aspects of the temporal lobe and the inferior medial aspects of the frontal lobes. EEG is still useful. No? The medial temporal lobe is highly epileptogenic, and the typical EEG pattern will show periodic lateralized epileptiform discharges or PLEDs repeating every 2 to 3 seconds. It manifests with 2 to 15 days after the symptom onset, and the absence of PLEDs does not rule out herpes simplex encephalitis. It may also show intermittent high amplitude slow waves or diffuse low wave. So treatment, of course, is your acyclovir, which is the first line treatment. For adults, give 10 milligrams per kilogram IV every 8 hours. For children, 15 to 20 milligrams per kilograms every 8 hours. And for resistant cases, you may treat with IV foscarnet or cidofovir. Alternate, if IV acyclovir is unavailable, you may give ganciclovir. And for viral infections, corticosteroids is controversial. Possible benefit, it may reduce your immune mediated damage, but it may enhance viral replication. So you may only consider in cases of severe cerebral edema or with mass effect. So again, ICU and supportive care, neurologic monitoring, seizure control, manage your ICPs, hemodynamic and airway support as needed. So your other viruses, no? So other herpes viruses or herpes simplex, that's what we discussed. Your varicella, which can cause encephalitis in HIV patients. It will present with altered mental status, ataxia, seizures, and usually negative in CSF viral culture. Okay? CSF findings will show increased WBCs, increased protein, normal or slightly decreased glucose. Cytomegalovirus causes encephalitis in HIV patients also. It will present with confusion, cranial neuropathies, polyradiculopathy in immunocompromised patients. Serology is almost always positive, and viral culture can be achieved through urine, throat, culture, and although that would not be proof of encephalitis. Your Epstein-Barr virus is rare. It causes rare encephalitis in mononucleosis, and monospot test is good presumptive test and may be negative in up to 20% cases in the first week. So human version HHV6 and 7 causes seizures and encephalitis in 1 to 3-year olds and may present with fever as well. So other respiratory viruses, such as your influenza A and B, they cause parainfluenza and occasionally others cause encephalitis. It may present with fever, headache, confusion, and possible seizures. So direct antigen ELISA test will be available for RSV and influenza. Your enteroviruses include your Coxsackie, which is prevalent in summertime outbreaks of meningitis and meningoencephalitis. It will present with headache, photophobia, fever, and neck stiffness. For arboviruses, You have your St. Louis encephalitis and your West Nile viruses, which are also prevalent during summertime outbreaks. Other viruses, of course, HIV may also present with its own encephalopathy. You will present with cognitive decline, motor dysfunction, and behavioral changes. Lymphocytic site choriomeningitis virus will cause meningitis, fever, myalgia, headache, photophobia. Your JC virus will lead to other diseases such as your progressive multifocal leukoencephalopathy, mostly in HIV and immunocompromised patients. It has a gradual onset of focal neurologic deficits, cognitive impairment, visual changes, and ataxia. And of course, you have your rabies virus, which has 100% mortality once symptoms appears. It will present with encephalitis, and the symptoms would be hydrophobia, aerophobia, agitation, paralysis, and sometimes coma. Okay? So I think that covers our viral encephalitis. Any questions? Feel free to reach out if you have any questions. Thank you.